Laryngomalacia is the most common cause of stridor in neonates and infants, characterized by a soft and floppy laryngeal structure that collapses during inspiration, leading to airway obstruction. Let's start with a brief look at the anatomical features and pathophysiology. This image highlights the narrowed airway typical of laryngomalacia, where dynamic collapse of the supraglottic structures leads to inspiratory stridor. Stridor often worsens with crying, feeding, or when the child is supine. Here, we see the hallmark omega-shaped epiglottis, a classic feature of laryngomalacia. This configuration is due to the inward folding of the epiglottic cartilage, contributing to the inspiratory collapse. Laryngomalacia is often self-limiting and resolves by 18 to 24 months. However, in severe cases, intervention is required. For most infants with mild to moderate symptoms, management is conservative. This includes positional therapy, such as keeping the baby upright during feeding and monitoring for growth and weight gain. Proton pump inhibitors, PPIs, may be prescribed to manage associated gastroesophageal reflux, which can exacerbate symptoms. However, when the condition presents with severe symptoms, such as poor weight gain, feeding difficulties, or significant airway obstruction, surgical intervention is considered. This is where supraglottoplasty comes into play. Supraglottoplasty is the primary surgical treatment for laryngomalacia. It involves the removal or reshaping of the excess or floppy tissue from the supraglottic structures to prevent collapse. Typically performed under general anesthesia using a laryngoscope, the procedure focuses on trimming the epiglottic folds or partially resecting the epiglottis. In cases like the one shown here, the surgeon would address the omega-shaped epiglottis, reducing the redundant tissue that contributes to obstruction. The goal is to create a more stable airway, allowing for improved airflow during inspiration. The success rate for supraglottoplasty is high, with most patients experiencing significant relief of symptoms and improvement in feeding. Postoperative care involves monitoring for potential complications such as edema, bleeding, or aspiration. In the weeks following surgery, the child may still require acid suppressive therapy to reduce inflammation and optimize healing of the surgical site. Key points for clinicians include recognizing the signs of severe laryngomalacia that warrant surgical intervention, understanding the role of endoscopic assessment in evaluating airway obstruction, and ensuring post-surgical follow-up is critical to monitor for potential complications and ensure recovery. Laryngomalacia might seem like a simple diagnosis, but knowing when to intervene can make a significant difference in the patient's outcome. Understanding the anatomy, management, and surgical techniques like supraglottoplasty is essential for any ENT specialist or pediatrician managing this condition.